So, welcome to the latest episode of MQ's Open Mind. And Craig and I are delighted today. We've got another fantastic guest, Professor Nav Kapur from the University of Manchester. So, welcome from both Craig and I, Nav.
Thanks. It's really great to be here, Rory. Thanks for having me on.
You're welcome in.
Okay, so Nav, how we try and sort of navigate our conversation as we try and begin, strangely enough, at the beginning, right? So, obviously, I've known you for many years, and as obviously a stellar suicide researcher, clinician, policy advisor, and lots of other things besides. But it'd be really helpful if you could maybe take us back to your beginning and sort of. And I know obviously I know you're from London, but trained north of England. So do you want to tell us a bit about that journey and how you got into mental health and then psychiatry?
Absolutely, Rory. And you've started as usual by kind of wrong-footing me by being nicer to me than you've ever been before. So thanks for that. And thanks for
Yeah,
that.
it's the only time, Nav. It's only time.
Okay, that's very good. So, I mean, it's about how far back you want to go, and I think I'm very conscious at the moment about university choices because my youngest is just at that point, and I suppose that's where it kind of started for me because I was always quite kind of sciencey, so always quite into science, but I thought I might become a physicist at one point, of all things, kind of learn about the origins of the universe and other things. But the choice was between something very pure like that and then something a bit more kind of people focused because I thought I'd be good at working with people and that, if you like, the people focused bit one, as well as thinking actually there's probably more of a career in medicine than being a lonely kind of physicist kind of beavering away on your own. Apologies to any physicists that are listening. So went to medical school, and medical school is quite kind of interesting. It's a bit like probably doing, health psychology, anything really. There's so many different things to kind of
Yeah.
potentially specialize in.
And that was at Leeds?
That was at Leeds, yes. I was born in London, kind of had enough of it after 18 years, moved north to Leeds unimaginatively, and this is a theme that will come up again and again. It's where my brother was at Leeds
Yeah, yeah.
doing medicine. So rather unimaginatively, I went to Leeds, but Leeds is a fantastic place, very different, the north of England for international viewers, very, very kind of friendly. So that was all great. And then, you experience lots of things as a medical student, but there were only really two things that really sparked my interest. One was general practice. So, talking to patients, the continuity there was really good. And the other was psychiatry. I just immediately found it kind of
Mhm.
fascinating. Whereas some of the more traditional specialties like surgery and kind of medicine, I thought, I'm not gonna do that. So they were the two things. And then I kind of fell naturally into kind of psychiatry. I thought, well, that's a specialism, and I'd quite like to be a kind of specialist. And so that was that. And I stayed in Leeds again, maybe a bit unimaginatively. Really, really enjoyed it. And then was just happily going on with my kind of clinical training. And then there was this new thing, and it was this new thing called evidence-based medicine. And I thought, that's newfangled. It will never catch on, this use of evidence in healthcare. But maybe I should maybe dabble in research. Maybe, I mean, it might be something I quite enjoy. I thought, no, I'm not going to. But then I got offered a kind of research job. I was kind of second choice. Good mate of mine in York was the first choice for that job. I won't reveal his name, but and I did it. And I don't know if you found this when you first embarked on research, but I just felt like I was kind of almost home. I
Yeah,
immediately
yeah.
kind of took to it. And that was that really. I did a year's research post, then did a master's. And back in those days, I think it's sad, with service pressures and funding pressures, this is less common now. But as part of clinical training in many in many fields of health and social care, not just psychiatry, you could do degrees alongside. So I did a master's alongside kind of clinical training, more research, again, honing research skills. And then I kind of never looked back. I came
What was it? What was Masters unknown of?
Sorry, what was a
What was a
master's?
Masters?
Master's was it was again mental health related, but it was on junior doctors. So it was which is really kind of quite
Mhm.
pertinent even now if you think about it. And what had happened was there was a kind of we were really worried about the one in every 3 nights that many of us were doing at that time, and working patterns had shifted, but they'd shifted to literally shift patterns. So
Mhm.
they'd gone from an on-call system to shift patterns, and we wanted to look at what effect that had on junior doctors' mental health. And anecdotally, it wasn't good, and some of the research kind of played that out that when they were on shift work, junior doctors' mental health was poorer. But that was my first kind of foray into, research that I, if you like, kind of led myself. I came up with the research question, but
Mhm.
again, felt very much had kind of taken, felt very comfortable in that world. And then Leeds was a great place back then. It wasn't one of the major academic centres, and but Manchester was. So I came over really just to have a kind of chat with one of the professors here, Bill Deakin, and he started talking to me about astronomy. So that kind of got me kind of interested, nothing about psychiatry or mental health research, astronomy. So I kind of got into it that way, and then came to Manchester as a much bigger centre, and then took a permanent job here. And again, rather unimaginatively, you can see the theme. I've been here ever since, and just went from lecturer to senior lecturer reader to professor here. So it's been amazing, really. But you know what it's like when you look back. It wasn't planned. It's just the way these things kind
Yeah.
of work out.
But how did you get it? So that I think you've told me just before an interesting sort of anecdote about how you got into the sort of suicide research field, or it links in with Lewis Appleby, and that. Can you tell us a bit about that? How you
Yeah,
get
yeah, yeah. So
into suicide work?
Lewis will smile as I tell this story. So that was later on. So basically, I'd started off in self-harm and suicide
Hmm.
research, like you had, did a bit of stuff on junior doctors, but then from an MD, so from a research
Yeah.
degree, my research degree, I was back in primary care again, looking at consultation rates, so nothing at all to do with
Hmm.
suicide or self-harm. But then I was looking for the next post, and the jump from lecturer, senior lecturer is quite a big one. You're always wanting kind of permanent posts, and they were talking about creating a post, and it was all very good in Manchester. But Lewis had a post, Lewis Appleby, who was then the government's most senior psychiatrist, so the National Clinical Director for Mental Health. He had a senior lecturer post to help run his research unit while he if you like, ran mental health and mental health policy for the government. But we'd had a bit of a falling out. We'd had a
That's a
bit
bit
of
of
a falling
remember.
out. So if interested readers can look back in the pages of the psychiatric bulletin where Lewis wrote an article. There was another article as well by an excellent colleague, Gethin Morgan in Bristol, and they were talking about this whole process of suicide risk. So again, very pertinent today. So this was back in the late 1990s, and Lewis's article was basically saying we need to get better with identifying, people who are at suicide risk, high risk individuals, and intervening. And on the one hand, that's an irresistible argument. You focus your resources on people at high risk. I think the point that we made, and he was National Clinical Director of Mental Health, and I was just a, junior, very junior researcher in Leeds. So along with my really good friend and supervisor at that time, Alan House, we wrote a kind of rebuttal. This registrar writing a rebuttal to, the National Clinical Director of Mental Health, saying, now, what you need is a population-based approach. So what you need if you really want to prevent suicide is don't just focus on the high-risk people, focus on everyone.
Mhm.
That prompted some colourful exchanges in the pages of the bulletin. So I think Lewis said something in one of his responses like Kapur and House raised an interesting point. They even seem to think they thought of it first. And I tease him about that now, and he said, "Yeah, it's all kind of all fair in the pages of academic journals."
Yeah,
So it
but I
has that
suppose,
spat.
yeah, but what's interesting about it is, I suppose it's, I mean, that issue about high risk groups versus population based approach is obviously a hot topic today, and it's obviously, as both of us know, in the field of suicide prevention, you can't have one or the other; it has to be both.
Indeed, indeed. But then I haven't told you the story about our rapprochement, our
Oh yeah, yeah. Sorry,
reconciliation.
yes,
So,
sorry, yeah, yeah,
so
yeah.
the other spat. So he had this job, and I'm thinking, well, I don't think Lewis kind of will like me very much, and oh, I don't know how this is going to go. So I went to see him, but it's a great job. And again, I was kind of second choice for that job. So someone else, really stellar person in Europe, had been kind of teed up for that, didn't take it. So I was a second choice. So I go around to Lewis's office, and it was in the old Withington Hospital. So it's this old kind of, 50s and 60s build. Even someone as important as Lewis at that point, the roof's leaking, there's buckets to catch the rainwater. I go and see him in his office, and he's got a screensaver on his PC. I said, Where's that?" He said, "Oh, I see the Everglades. I've just been with my kind of three kids," and he started talking about kids and families, and I thought, actually, this isn't the frightening kind of academic that I kind of imagined. And we got on very well, kind of personally as well. And I'm pleased to say that despite, I don't know, 20 odd years working together, we've continued to work well. And why that worked well, I think in particular, is Lewis was doing some of that national
Yeah.
policy stuff much wider than suicide prevention. And as a quite junior person, I was allowed to, if you like, run a research unit, and that I think worked really well for both of us. And it's been a very productive academic collaboration ever since.
No, I think that's a yeah, that's a great story, I think, to tell it. And I think good advice for junior colleagues is always don't hesitate to, it's not about the hierarchy, it's about engaging in healthy, respectful debates. And in this case, you did that and it worked out very well for you. And you continue to do it. Yeah. And I suppose,
I like to think I'm no longer, the research registrar in this
yeah, yeah, yeah. No,
relationship.
but it's
But
good advice
despite
for others. It's good advice
Oh,
for others.
absolutely,
Yeah.
absolutely. And I think the other bit of that, and I don't know what you think about this, is actually not worrying too much, about, I mean, some people get kind of quite a bit narked if they're not the first person someone's rung up or the first choice of collaborator. In the end, it kind of doesn't matter. It's about
Yeah.
what you make of it, really.
Yeah, oh no, absolutely. And but it's also I think the other bit it's a personal relationships thing. It's working out who you can work with. And I think we've all learned that over our careers is that's for me the most important thing. That's work the chemistry between you and your collaborators. And
Oh, absolutely, and your mentors as well. I don't want to embarrass Lewis too much, but in part he's a kind of mentor to me as are others. But
Mhm.
that's the other thing I always talk about. It's about stealing different things from each of your mentors.
Yeah,
Really,
yeah.
that I think is a really interesting thing.
Well, that brings us right up to date. And obviously, Nav, you're currently Professor of Psychiatry and Population Health at the University of Manchester. You're honorary consultant psychiatrist at Merseycare NHS Foundation Trust, and you're the director of the National Confidential Inquiry into Suicide and Safety in Mental Health, as well as being health head of research at the Centre for Mental Health and Safety. So I've got all that out
It's
now.
good. It's great, isn't it? When people list your affiliations and they're longer than the talk you're about to give or something. So yeah, I'm all of those things. It's nice to hear as well. Nice to hear back.
No, it's an impressive. And the other bit, obviously, when we talk about is your work with NICE and the National
Yeah.
Institute of Health and Care Excellence. But maybe if we, well, I'm just saying, which do you think we should talk about first? The work, your NICE-based work, or delve into some of the research work you've been doing. Which would you think we start off with?
I'm very easy. Since you mentioned the nice work though, that I think that fits with a kind of career
Okay.
development kind of thread that we've been talking about. Because I think that's the other thing. Even when you're quite kind of been around for quite a while and are quite long in the tooth, as we now are, Rory, we're no
Yeah,
longer the young ones on a block,
correct.
are we? Although sometimes we behave like it. I think realizing different things come along and seizing those opportunities. So I didn't, the nice guidelines, there was a thing about, contributing to committees or actually chairing a nice guideline. And I thought I'd probably be all right at that and I wanted a go at it. But I hadn't realized that I was, I would be quite good at chairing. It's a
Yeah,
weird, it's not part of a kind of core, I think, academic skill set to begin with. So again, it was one of these things I tried and I kind of took to. And I think as a researcher, it's absolutely fantastic. It's a privileged position to be in because you can see how the things that you and I generate in the lab or using the databases actually feeds into the real world. And that
yeah.
to me has been the biggest reward in my career, really. Just seeing that translation and seeing that impact. So the nice stuff was great from that point of view.
Well, let's get into some of that though. Let's get into some of that because
Yeah.
so you're involved in four NICE guidelines, to my understanding. You chaired the self-harm guidance development in 2011. You were chaired the depression guidelines more recently. Your topic advisor for, as it when NICE changed the way they did things, for the suicide prevention guideline and for the more recent self-harm guideline. And obviously, when you were mentioned earlier about your chairing skills, I was when you were chairing the self-harm, the first 2011 one, obviously.
Yeah, there was a young whippersnapper on the on the committee called O'Connor who was very difficult to chair. No, you were
Yeah.
you were a
Well,
pleasure. Yeah, it
but
was
but but
brilliant.
again, it was a great example. I mean, I saw your skills firsthand. It is a difficult task, and maybe for the people who listen to this or watching this who don't know how we go about the NICE guidance. Do you want to say a bit about that process, and then maybe combine? I would be really interested to say something about what do you think the most important messages, say, for the most recent self-harm guideline or the suicide prevention guideline?
Yeah. So for nicer kind of world leaders in guideline development, they've been at it a long time. The first self-harm guideline, I think, was one of the earliest ones back in the early 2000s. And they've got, I mean, the big strength is an established methodology.
Mm-hmm.
And part of that established methodology is a reliance on the research evidence. So lots of emphasis on high quality systematic reviews, either taking ones that have been done or quite often repeating them in-house. So that's one thing, this reliance on evidence. Another bit of the NICE guideline process is, a focus on health economic considerations. Because, it's difficult, isn't it? People talk about rationing and other things, and it's not about rationing, but it's about we've got limited resources, we've got to spend that resource in the most cost-effective way. So one bit of the NICE process is about evidence, another bit is about cost effectiveness. But the third bit is about how you turn that into actionable recommendations. And the way NICE do it is they have committees. So they have committees of people with complementary and wide-ranging expertise, experts with lived experience, to researchers, to clinicians, to policymakers, primary care. That they have this wide variety of people around the table. So I can't remember how many people were around the first self-harm guideline. Must have been about 20 of us, were there?
Yeah, I'd say it must be about 20. Yeah,
Yeah.
yeah,
So back in the olden days, and I do like some of the old kind of face-to-face stuff. So nowadays, I think many of the nice meetings are online. But back in the day, these were face-to-face meetings around a long table. We'd consider the evidence. We'd think about what that evidence meant. We'd think about how relevant it was to our context, and we'd then come up with recommendations. But there were two challenges, I think, in that kind of process, and two particular skills. First is what do you do when the evidence is a bit kind of
yeah,
contradictory? How do you kind of prioritize it? And the second, even more challenging thing is what do you do when there isn't the evidence?
mm,
And then I think it's the skill of the committee members, it's the skill of the chair to try and get a kind of consensus. And that, for some of the guidelines, was the most challenging thing. Different people with very different views trying to steer a course
yeah,
that's going to be, so it's got to be two things. It's got to be something that isn't innocuous. So it's not something that's so inoffensive and innocuous that actually it's of no use. So it's got to be of some use. On the other hand, you've got to have something that people sign up to. So, yeah, bringing people with you, I imagine it's what kind of trade union kind of mediators do. If you're mediating an industrial dispute, sometimes it's a bit like that. But I think what you have to keep an eye on there is, and this is the same with many things, is eyes on the prize. What's the prize here? The prize is something that's going to be useful, for example, to, if you're talking about the self-harm runners, clinicians on the ground,
yeah,
that's actually going to improve the care that, patients, that service users get. So that, I think, is a really tricky thing, and you can never please everyone all the time. So sometimes people are unhappy you've recommended something. Sometimes people are unhappy you haven't gone far enough. Sometimes people are unhappy with the vagueness of the recommendations. You'll know this story. One Friday, I opened the pages of the BMJ when we were chairing the depression guideline, and saw a article kind of co-authored by 50 colleagues, 20 MPs, presidents of various royal colleges, saying that the NICE guidelines for depression weren't fit for purpose, and having to then kind of, and they were, and people had some legitimate concerns, and some concerns that I think were perhaps, more easily addressed, and we steering a path through that was incredibly challenging. But then what you end up with is you end up with a guideline, and bringing us then to the most recent self-harm guideline, perhaps
Published
what
2022.
yeah, 2022 guidelines again. I was expert topic advisor on there, so nice move to a situation which makes sense if you like. There were non-expert chairs. So the chair was
Mhm.
a great guy called Jeremy Isaacs, neurologist from St George's. But I was on the committee and there to kind of provide a kind of expert view. The things for me there are some of the things we've been saying for a long time. So this idea that someone can hurt themselves, they can come to the attention of health services, and then no one with a specialist knowledge of mental health sees them. I mean, to me, that's kind of almost scandalous. And yet we know that
Bizarre.
in
Yeah.
about half of people, they weren't getting what we'd call a kind of psychosocial assessment, a proper assessment. We weren't getting them coming for self-harm. So for me, that's one of the things others actually have been talking about since probably 1984. So the earliest Department of Health guidelines on self-harm, 1984, make sure everyone gets an assessment. So some things we've been talking about a long time, I think they're still key. We can't, those of us involved in services let our guard down. That's something we need to keep pushing at everyone getting an assessment. And it is very, very difficult out there. I go to emergency departments. I talk to lots of colleagues who do mental health, who do psychiatry in general hospitals. It's really resource
Yeah.
pressured. Seeing everyone's a big, big challenge in many places can't do it. But that's one thing. The other thing I think people have kind of accepted that now. So for me, and this will be, I think, right up your street as well. I'd be interested to hear your thoughts because it's about the intervention. So it's about, we've got a bit of an evidence base now for what works. So
Yeah.
talking treatments after people have self-harmed, they're effective, but they're just not available. They're just not available. And we can make the arguments about cost effectiveness, i.e., you provide these things and you save money in the longer term, but they're still not really out there. So for me, that's one of the big frontiers. I don't know. What do you
Well, no, I
reckon?
think that's right. I suppose that I think there's a couple of challenges which we came up against in the guidelines and the real world more widely is, yeah, we've definitely got an evidence that some talking therapies work. CB, cognitive behavior therapeutically informed interventions for self-harm seems to be most effective, right? So one is accessibility, as you've highlighted, but the other bit, and we discussed this a lot across the both guidelines. We think about the fact that that first NICE guideline I was involved in for self-harm was 2011. There was one previous to that, which was 2004, as you mentioned. But then if we think about the development between 2011 and the subsequent 11 years, 2022, so we were still saying very similar things across both guidelines. And I suppose the bit which disheartens me a little is the lack of understanding we still have. So on those self-harm guidelines, yes, we can say CBT informed interventions work, but as we well know, we can't say how many sessions. We can't say what the active ingredients are. We can't say anything really yet about the therapeutic alliance, broadly speaking, and that's changing. And we can't say who they work for, right? So I think that's a challenge we still have in the field.
I think we do, and I think it might be interesting. I think we've got slightly different views on that, which is always interesting. So what works best for whom? I think absolutely. I think part of me though, with my kind of clinician, if you like, policy head on, is about well, actually, I'm not sure we should be spending too much more time and effort kind of refining when we've not got the basics implemented. So
Mhm.
that's perhaps where you and I might differ.
No, no, I would agree. I would agree with that. I
Yeah.
suppose, yeah, maybe I'm arguing for I would like a bit more evidence, but fundamentally, though, I think we have to be delivering what we're saying in the
I,
guidelines.
I
Fundamentally.
reckon so. I reckon so. So the psychological interventions, I think, is a massive piece. And I've thought, over the years about how best we provide that, who provides it. I mean, ideally it'd be liaison psychiatry teams, but I talk to them all the time. They're under such great pressure. Many of
Yeah,
them want to,
huge
though.
question. Yeah.
Many of them want to. Many of them saying, well, we haven't got really that much to kind of help people or refer people onto. So actually providing something would be fantastic. So that's one of the other things I think. I mean, the other thing that I'm guessing we'll talk about at greater length is the whole risk assessment stuff. And there's this idea,
Well, let's move on to it now. So when we set that
yeah.
up, then what are the challenges? What's the big debates in the area?
So again, this has been going on for well, this has been going on for donkey's years. So the first article we found on that was kind of 1964. It's only 1964 because that's when some of the databases started. But this is an argument that's been going on in donkey's years. And at its heart, I think there is a almost a kind of irresistible argument. And it's this idea that look, in mental health, we've got limited resources. We have to focus our resources in some way. So what we need to do for suicide is look, let's think about who's at greatest risk. So
Mhm.
which groups have the greatest likelihood of suicide or maybe repeat self-harm? And then let's, throw everything we can at that group. And, then we'll make a difference. And that, on the face of it, is almost a kind of irresistible argument. The problem with it is that what we're talking about here is picking needles in haystacks. So even if we're talking about mental health and we know people under the care of mental health services or people who present with self-harm are at greater statistical risk of
Yeah,
suicide, it's still only 1 in 100 people. And don't misunderstand me when I'm
yeah.
saying only, very well aware, having worked in this area for so long, the importance of individuals in this,
And the
in this
devastation
field.
left behind, every
Yeah, yeah,
family
yeah. I mean,
devastated.
you and I are very
Yeah,
familiar with that.
yeah,
But in the service challenge then is trying to pick that one person in 100
yeah.
or sometimes one person in 1,000. And that, no matter how good you make your tools, you make your assessment, that is going to be impossible to do because what you always end up doing is you end up maybe capturing some of those people who actually, would have had the outcome, the devastating outcome, but you miss all the people in the low and medium risk groups. And that's the fundamental problem with the high risk
Well, and one of
approach.
your studies previously obviously shown that if we look at statistically technology or the terminology in terms of false positives, that we get it wrong most of the time,
Yeah.
95% of the time.
Yeah, now it's lovely that statistic because it's one of these statistics that we came up with and then people quote it back to us and they don't know that, it was us that kind of came up with it. And you have to be a little bit careful with that statistic. It's about where you set the threshold. That
Yeah, yeah,
statistic comes from a paper by a really good mate of mine, Greg Carter. I was an author on the paper as well, where he reviewed all the scales and he looked at what we call the positive predictive value. And that's a marker of, well, if I rate someone as at high risk, how many of them have, the devastating outcome? And the answer to that was in Greg's study, 5%. And that means you rate 100 people at high risk, five of them actually go on to have the outcome. In other words, you've rated 95 people as at high risk who don't go on to have the
yeah,
outcome.
yeah,
Now, partly, I know, people, but, and people got very valid, counter arguments against some of this. They say, well, you can alter the threshold and you can, but with the 5% threshold, it's not even that you get it wrong 95% of the time. It's the people you've excluded. And that is the
yeah.
big problem with risk assessment. That by its nature, you are using it to kind of focus your efforts. But by focusing your efforts, you're ignoring a lot of the people who are at statistically lower risk, but they're a bigger group.
Hmm.
Now, you can change that positive predictive value. You can because you can rate loads more people as at high risk. But that, if this is about kind of changing thresholds, but then if you rate many, many more people as at high risk, then you're intervening with many more. So it's this whole balance.
Yeah.
But the
But it's
problem, I think,
the reality is also though, isn't it, that I mean, as we often, I mean, that although every death is devastating and we want to prevent as every death we can, the stark reality is in the statistical probability context on a population level, most obviously 10 in every 100,000 people will die by suicide in the UK, broadly speaking. And so, go back to your point about the proverbial needle in the haystack, you're trying to identify this really difficult task, and we would call that a low statistical base rate. Even though every one of those deaths is a devastating outcome. So in a way, the question might be, and you've talked about this before, I've talked about it before, is it the fallacy of prediction, right? So that's what we're really getting at here. So do you think we'll ever get to a stage then that we will be able to predict, or do you think it's a wrong question?
right, it's the wrong question. And this whole thing about prediction, and excellent colleagues, will say, well, there is statistical validity in prediction, okay? Because actually, if we estimate someone as a kind of, I don't know, 25% probability of dying over the next 10 years, we can actually look at real world data and they do. And this particular factor, be it drug or alcohol use, increases the risk by that much.
Yep.
Yeah, so when I talk about the fallacy of risk prediction, do tools, do assessments have some predictive value? Yeah, they do
Yeah.
statistically. But what I'm talking about is the person in front of you. And I'm saying, well, actually, for the person in front of you, that high, medium, low risk rating is kind of meaningless.
Yeah.
I would argue even a score is a bit meaningless in many ways. Because what you need to be focusing on is that A, what their needs are, and think B, what you can do something about. So modifiable risk factors. People might say, well, actually, that's a risk assessment by another words, because you're talking about a needs assessment. So it's actually the same as a risk assessment. It's not. It's not in a very important way, because what you're not trying to do is focus and specifically mitigate against an outcome that's difficult to predict. What you're doing is you're intervening according to their needs
Yeah.
here and now. So my view would be it's this old, the population-based approach to even mental health services. So I work a lot in mental health services. So what I often say to clinical services is I say, well, this is an uncomfortable message, but actually, if you like, anyone that comes to your services is to some extent at high risk, okay, high statistical
Yeah.
risk. What does that mean? So what that means is not, you shouldn't encourage defensive practice. That's another problem, not just the exclusion by the way of risk assessment, it's the defensive practice that risk assessment kind of encourages. So not only are you preventing that kind of defensive practice, you've got to kind of mitigate against that. So you've got to kind of think about what you do instead. And what that means in practice is doing something for everyone. That means, and it's a clinical mindset. It's, well, okay, I'm not going to be able to admit everyone. I'm not going to be able to refer everyone into the community teams. But actually, no patient of mine is going to leave my care kind of empty-handed, whether that's meaningful signposting, whether that's some meaningful advice on self-care. And it's getting back to something else you mentioned, which is sometimes one of the things we ignore. And one of the things, again, I think risk assessment can interfere with is the relational
Yeah. Yeah.
aspects. So that's another, if you like, disadvantage. I mean, you can look at AI, you can look at, other things, and again, it's another irresistible kind of idea. It's suicide's complex. Machines are brilliant at dealing with complexity.
Yeah.
Therefore, machine learning is the answer to suicide risk prediction. Again, I think it's the wrong question. You're never going to be able to get something that picks that that person who you should be worried about. And I think you can use it in other ways. So the AI, whole AI stuff, use it as clinician prompts, think about it in knowledge support tools. So bringing the learning to clinicians in real time. So for me, it's the wrong question, the prediction question. But I've got respected colleagues who argue it another way. For me, in the end, I always say, look, I've changed my mind. I'm very happy to change my mind if convincingly someone can show that it does more good than harm. And that's where I'm at, really.
Oh, well, that's a good place to be. And I think on the AI stuff, I think it's certainly not going to be the magic solution for prediction or assessment, I don't think. But yeah, we have to engage with it. We do have to do it in an ethical way. We have to make sure. I think I have a lot of concerns about potential harms of AI, and we know already there's evidence that it is associated with a lot of the data is very homogeneous populations, and it's just of implicit risk, which racialization goes on. There's lots of issues we need to be careful of, and confidentiality, lots of stuff. Never mind the energy required and the impact on the global economy or global world, and especially the global south and these things. But I suppose we probably don't have time to go into those details now. I want to move us on now. That's a really helpful conversation on the complexity around risk assessment. I think what you're saying, to summarize it, I'll summarize what you said, is it's complicated. It really is complex. But what you want is a system which improves the care for everyone, which is personalized to their needs.
Yeah, I think that's absolutely right. And in a sense, it's a subset of why I've, really, passionate about kind of suicide prevention and self-harm intervention, because for me, working in services, it's that vanguard issue, right? So it's if you do the things that hopefully prevent suicide, prevent repeat self-harm, if you put those things in services, you're going to improve the care for every single patient. And
Mhm.
it's a bit of a variant for that. So rather than trying to focus necessarily, who's the high risk people? That's the people we've got to worry about. That's the people we've got to be extra defensive about. It's actually, look, let's think about improving the quality of care for everyone.
Okay, well, on that note, that brings us nicely onto some of the really similar work that your group and you have led on. How many years is the National Centre now? It's now 20, 30 years old, is it?
Yeah, 1996. Yeah.
So come up, well, 30 years next year, but
Gosh.
in your 25th year, he's published this great review, and this is all underpinned by Lancet papers and lots of other things, and lots of really high quality publications. But you came up with a 10 safer services sort of recommendations. Do you want to tell us
Okay,
a bit
now
about that?
as academics, we love to take credit for things, even when they're not quite fully our work. So, I'm going to start with a little bit of disclaimer. So, these were 10 things that we kind of distilled from, bits of our work, some big national studies where we looked at implementation and effects before and after. And that's one of the big privileges of being involved in the National Confidential Inquiry, from my point of view. You can go from the research, you can make recommendations, and then you can see the impact of those recommendations. So these
Of
these were
course, it's a
themes.
team effort. I don't dispute it's a team
Yeah, yeah.
effort. Yeah,
And just a privilege to be part of it. And we kind of distilled some of the messages into ten ways to improve safety. And my friend and colleague Lewis Appleby said, we should put these into a little kind of cartoony infographic thing. And I said, no, look, that's never going to work. That's never going to work. We can't reduce this complexity down to one slide, 10 things. It's never going to work. But if you like Lewis, of course, let's do it. And of course, that's our single most popular slide. You
yeah,
can you can guarantee you put it up at a meeting and there's all sorts going on, Rory. There's, pictures of you and me. People not interested. There's, great high quality research. People aren't interested. But you put the slide up of 10 ways to safer working,
yeah,
and people are always kind of taking a picture of it and things. And I think it's very neat in a way. Every bit is evidence based. Some of it is underpinned by stronger evidence than some of the
yeah,
other bits, but I think, very, very kind of helpful. And, I know chief executives, I know people in mental health services who have it up on their wall and kind of do it. But underpinning that, there's all sorts of things. There's the research, but then there's also a toolkit where services can kind of
mm,
map their compliance against it. And we know elements of that are effective. So going from the very specific, so improving safety on inpatient mental health units to more general things, so such as kind of adherence to guidelines, to liaising with families. That's something we've been rubbish at in mental health. Certainly when I started, we were really not very good at that. I think that's getting better, the involvement of families and significant others as part of core mental health care, to even, other things as well, other things that sometimes people don't think about in terms of suicide prevention and safety, which is looking after our staff. Because
yeah,
we know that staff who are happy, who are settled, an organisation with a low staff turnover, so staff who are kind of don't move, is a safer one. And that's not just a marker of the organisation. That's because of things like continuity of care. If you've got staff who know the patients, who know the service users, safer. So thinking about those, I think, has been a really kind of new development. So there's all sorts of things there, and obviously on the websites and widely available.
if you just Google University of Manchester, NKISH, is it still is the NCISH, and you'll find it in suicide prevention. Okay, now that's really helpful. Moving in a slightly different direction for a second, right? You've been working in suicide and self-harm now for whatever, a long time. What
Thanks, mate.
I was trying to work
So
out
have
about,
you.
yeah, so my notes about 30 years, right? So what do you see as the most misunderstood aspects of suicide prevention, suicide risk, or whatever aspects of us trying to understand and prevent suicide?
So this is a really interesting one, and if you like, the easy answer here would be, well, it's one of the things we've already talked about, which is this notion of suicide high risk, and that's how
Yeah,
you do things. So that would be an easy answer. But the other thing I think that's really quite misunderstood, and it's pertinent to the space in which I work, which is not exclusively by any means, and we do lots of general population and public health type stuff. But, if you like, the core bit of our business is in mental health services. So one of the things I think I come across less now, but I did at the beginning, is mental health services saying, well, hang on, Nav, is this really a core part of our responsibility? Because, people again quote a statistic back at us that one is one of ours, which is, well, only a quarter of people now
Yeah,
are in contact with mental health services in the year before death. Surely it's all those other things, the social factors that as clinicians aren't within our gift. And my response to that is, well, a quarter of a big number is still a big number.
yeah,
One of the things we know is that, well, mental illness, if you want to conceptualize it like that, mental distress, which is how perhaps I'd prefer to conceptualize it, is a major factor in many of these. So actually, distress is a core part of mental health services, core part of the business of mental health services. So if we're thinking, some of the older studies suggesting 80 to 90% of people have, psychiatric diagnosis or some element of psychological distress, that then becomes a core bit of the business, even for people who aren't in contact with specialist health services. The other bit is it's not just specialist mental health services. So 25% are in contact with specialist mental health services, 50% are in contact with 50% are in contact with emergency departments, 70 to 80% of people are in contact with their primary care teams in the year before death. So this idea that services can have a core impact, I think is really important. And then it's the vanguard issue. It's saying to clinical services, look, by doing some of the things we know are effective for suicide prevention, you're improving the quality of care. So
yeah,
I think this, it is, and it's understandable sometimes, this idea that, oh no, we're powerless to prevent suicide in clinical services because it's a social phenomenon, it's a
mm.
societal phenomenon. That's the thing I think I've spent a lot of time kind of battling against and hopefully is now more understood.
Okay, so that sets up nicely for some of my next sort of question, which then, right, so we focused a lot on this conversation on mental health services. What we've alluded to, and you've just mentioned there now, about this sort of wider social determinants, public health perspective. Based on the sort of what we know, what should we be doing? Or what would you want to target in a sort of public health context, which you think would have the biggest impact in preventing suicide?
It's really interesting about the public health measures because there are some reviews that have kind of touched on this over time, but it's this idea of suicide specific measures, things that are specifically targeted on suicide prevention versus things that are almost incidental. So many of the listeners and the viewers will know about reducing availability of suicide methods, and there are examples of that. So catalytic converters on cars reduce suicide. But it was a ecological, it was a, it was
It
an
wasn't designed for
environmental
that
measure.
purpose.
It was
Yeah,
an
yeah,
environmental measure.
yeah,
It wasn't that. So there are these things that perhaps aren't directly targeted to suicide prevention that I think, could be profoundly powerful. One of them, I think, is, and probably underexplored, is the role of alcohol consumption.
yeah.
Certainly in many Western countries, and thinking about things that I know you guys have done north of the border. Minimum unit pricing, thinking about availability of alcohol. Both long and short-term effects of alcohol we know increase suicide and self-harm. And the other thing I think, I'm sure you'll have previous guests will have talked about this a lot on your podcast is the role of economic factors
Yeah.
and what we can do to mitigate those. And there's a classic studies from Oxford, David Stuckland and colleagues, thinking about policy response. Economies crashing, economic stress is bad for mental health. It's bad for suicide prevention. I've shown that again and again and again. What can you do about that? Well, possibly what you can do is think about increasing welfare spending, increasing mitigation effects. So you increase welfare spending, that's things like employment schemes, that's things like benefit levels. And the observational evidence is you mitigate against some of that rise. So that I think is a massive thing. And politically again at the moment really, really pertinent. And
Mhm.
I have sympathy for some of the kind of political dilemmas and pressures, but what we're talking about here is health. We're talking about, the impact on future generations, particularly young people, and thinking about how we mitigate the effects of some of those, the economic strains that everyone's feeling at the moment, I think is really, really important. And then, you've got the other evidence that you and I are very familiar with, coming from low middle income countries. So, Diana Machad's work, thinking about, and people are always amazed. I don't know if you find this when you talk about in the UK, this idea of cash transfers. So this
Yeah,
idea is giving people money and that, helping to reduce suicide and self-harm. I mean, it isn't just giving people money, it's conditional. So
yeah.
it's about, getting people to participate in child vaccination programs, making sure kids go to school. It's a wide variety of things. But that I think is potentially kind of really,
Mhm,
really
mhm.
powerful, and we could learn about that. But I think we come up against the kind of practicalities here. You come up against the, if you like, the real world nature of, governments, countries don't have limitless amounts of money.
Yeah,
How are
yeah,
we
yeah.
gonna spend that?
Yeah, but I mean, as we've said many times, is the idea that if you don't buy the ethical, the sort of moral argument,
Moral, yeah,
the human suffering argument, the economics are also really strong, as we know from our colleague David McDade and others who've led on this, and that there's different estimates, but one of the most recent estimates is the economic cost, as we know, of every suicide, broadly speaking, in the UK, is about 1.5 million. Now, obviously, that there's lots of ways in which that can be deconstructed, and I hate putting the value of money on somebody's life, but it's a really powerful argument when you're trying to make the case at a policy level. Okay, now we're coming towards almost to the end of our time together. I have one substantive question to ask you, and then we try and end with two sort of unrelated questions, as this is a pretty heavy conversation we've been having. So, but is there, before I ask my last main question, is there something you were hoping that we would ask you about that we haven't had a chance to talk
I don't think so. It's been very pleasant kind of afternoon chat, hasn't it, Rory? I don't think so. But if you think of anything, come back to me. It's fine.
Okay. Well, no, I think we've covered a lot, so it's been really good. Right. So this is primarily a research podcast sponsored by a mental health research charity, the only dedicated mental health research charity in the UK. What areas, if you're thinking looking ahead over the next 5 to 10 years, right? So where should we be investing? Where do you say our urgent priorities for suicide prevention research are?
I mean, we've touched on this a little bit, I think, already. For me, I mean, and it is research. It's about implementing what we know and then looking at the effects of that. So, if you like, it's almost for me, the priority is almost in situ evaluation and really kind of shifting into kind of implemented because you'll know as well as I do, health services are really pressured, mental health services in particular. We need to do something and we need to do something fast. And
Yeah.
I think that idea of implementation is really important. We're really good in mental health services, I think, innovating, pretty good at implementing some of the time. But even when we implement, we don't measure. So you've got to have all those things. You've got to innovate, so you've got to get new things. You've got to implement the thing that hopefully, research has shown is effective. But then you've got to measure, and we've been poor at measuring. Last year we just put out a paper looking at the effects of 7 years of kind of quality improvement and implementation work across the UK. And, it did have beneficial effects. It galvanized activity, it got people going, got people interested. But in terms of outcomes, the outcomes were pretty limited. We didn't get services collecting them. So that I think for me would be the big priority. I accept that's from a service
Yeah, but
lens.
that's really important, really important. Okay, well, thanks for that then. Okay, so now on to our sort of unrelated section. There's
Yeah,
two quick fire questions, and they're a wee bit left field, but let's see where
yeah.
we go with them. So the first one is, what's something you used to believe strongly, but you've changed your mind about? And it can be work related or unrelated to work.
Yeah, no, so again, some of the things we've talked about risk assessment, about other
Yeah.
things, I don't the thing I remember though is going back right to the beginning. So the thing I used to believe very strongly is that most researchers and academics were self-serving egotists. Honestly, so I remember being a clinician and thinking, they're just in it to, make themselves academically famous, etc. And I've changed my mind on that. I think the majority especially in the suicide prevention
Yeah.
field where we work. They're lovely people, very able people who are actually just wanting to do some good. So I've very much changed my mind on that. Although I will warn you, there are still some people out there who are self-serving egotists.
Okay.
Not us, obviously. I don't think.
Clearly. That's an interesting answer. I didn't think I was getting that answer. Anyway, so okay, our last one before we draw to a close. Okay, so this can you wake up tomorrow morning, right?
Yeah.
And you've got a superpower. It's only for 24 hours. So what is it? What is your superpower?
Yeah.
And what would you do with it?
Yeah, okay. So we're not going to go for a cheat superpower like the ability to grant wishes or anything like that.
No.
I think something about, we meet lots of people during our working lives and on a particularly busy day, so I'm seeing lots of different people, the superpower to just be able to spread a bit of happiness and contentment.
Mhm.
To kind of everyone you meet, and it's not just the usual kind of just to kind of foster a sense of well-being in everyone you meet for one day. I think that'd be quite cool.
Yeah, that's a great one actually. Yeah. So and you do that some days now. I've seen you do that some
Some days.
maybe maybe not every day. Okay, now on behalf of MQ, thanks a million for taking the time to join us today, and look forward to see what the next 25 to 30 years bring us from you and your team.
Well done, and I'm sure we've been meeting plenty of times in the interim, Rory. Thanks very much. It's been a real pleasure.
Thank you.